It's an absolute great pleasure for us to have Sarah Edward from the University of Leeds, from the St. James University Hospital, to talk to us on spindle cell tumors. Sarah is an expert of soft tissue pathology and also dermatopathology, and they have a very nicely working group in Leeds, a group of 3 dermatopathologists who are handling more than 10,000 specimens yearly. And Sarah is specializing on molecular tech. Sarah, or Dr. Edward, I should rather say, very active in the international connections as well. And one of the biggest conferences in Europe for dermatopathology is held in Leeds, and she invites international expert of pathology, dermatopathology, and those meetings are always a lot of fun. And she's a lot of fun to interact with and extremely knowledgeable. So we are extremely grateful for you, Sarah, to giving us this lecture at this very inconvenient time, as it is 11 o'clock p.m. For you. And because we are a little bit late, I would like to ask you to start with the talk.
Thank you, Laszlo, for the kind words. It has been my pleasure to participate in this great program which Laszlo Karai and Laszlo Igali from Norwich Hospital in the UK are organizing, and it is my pleasure to do this talk, and I will make an attempt to tell you what on a day-to-day basis we encounter with regards to cutaneous spindle cell tumors. To begin with, I would like to take you through. Now, I just want to take you through to spindle cells, what we really mean by spindle cells. As you can see on the screen, the 2 different types of spindle cells that we deal with are mainly the smooth muscle cells, where you have a lot of pink cytoplasm and blunt-ended short nuclei, and then the other major type of spindle cells are the ones with elongated and wavy nuclei. So for these cells, we broadly give the name as whether they are neural cells or myofibroblasts. Now, differentiating between these 2 cell types is of crucial importance in deciding what spindle cell tumor we are dealing with. So immunohistochemicals, of course, at the end of the day, morphology helps a lot in deciding what the cell type is. But immunohistochemical stains, as we know, are also important in deciding these cell types. Now, when coming to smooth muscle cells, as I said, they have abundant pink cytoplasm and blunt-ended nuclei or cigar-shaped nuclei, as has been described very famously in all our pathology textbooks. As you can see here, the nuclei have got quite sharp, blunted ends, and the cytoplasm is plentiful. And when they are stained with immunohistochemical stains, they stain strongly with smooth muscle actin and H-calrS1. So that is of smooth muscle cells. And as opposed, the myofibroblasts are skinny cells with elongated wavy nuclei, and the nuclei have tapered ends, and when they are stained with immunohistochemical markers, they stain with calpain. They also stain with SMA, but the staining pattern for SMA is different, as in they stain giving rise to a characteristic tran track appearance, that is a membranous stain, as opposed to smooth muscle cells staining both nuclei and the membrane. Now, for neural cells, that is one of the cell types with this tapered, elongated nuclei, they stain strongly with S100, as we all know very well. So broadly, when you classify these spindly cells, you have a group called smooth cells with blunt-ended nuclei, abundant cytoplasm, and then cells which are myofibroblasts or neural cells, and they stain differentially with smooth muscle actin for myofibroblasts, giving rise to the tram track appearance, and S100 staining the neural cells, as you can see very well on this picture here. Now, smooth muscle, the differential staining pattern, as I was saying, for smooth muscle actin, for myofibroblasts, they stain characteristically, giving rise to this tram track appearance. The nuclei are differentially spared. You can see the membranous staining, whereas here, the smooth muscle cells stain the nuclei as well as the cytoplasm and the membrane, so it gives rise to a dense, diffuse brown color. So in that way, we can differentiate the myofibroblasts from smooth muscle cells using smooth muscle actin. And this is crucial when trying to decide most of the time when you have a spindle cell sarcoma or a low-grade spindle cell tumor removed from any part of the body, trying to decide whether it's a smooth muscle tumor or a myofibroblast. These features come into play, and it helps quite a lot. Now I'm going to take you through some cases which I had recently to understand how we can delineate or help in making a diagnosis of smooth muscle tumors. Now, the first case here was a 56-year-old female who presented with a firm thickening on the elbow. And this is a representative section. And here you can see the epidermis there and a bit of relatively normal looking dermis. And then in the deep dermis and extending into the subcutaneous fat, you can see a very pink, very ill-defined tumor showing these spindly cells. So this is a scanning view where you can easily identify that there is an abnormality going on in this deep aspect of the tumor. Now, another view showing that these tumor cells, where you can see these tumor cells here, they are extending down into the subcutaneous fat. That is one of the crucial factors which helps to decide how well these tumors behave ultimately. Now, this has been labeled cutaneous leiomyosarcoma for the simple reason that, again, with the morphology of the cells, as I've shown you earlier, showing cells with a lot of pink cytoplasm, discontented pleomorphic nuclei, hardly any mitotic activity in here, but the tumor cells extended to the subcutaneous fat. That is the features we take into account in deciding whether these cutaneous smooth muscle tumors are benign or whether we could label them as leiomyosarcoma. So the summary is these cells which show the characteristic features of smooth muscle cells proliferating in the dermis when they extend into the subcutaneous fat or show evidence of lymphovascular space permeation, then they qualify to be labeled as leiomyosarcomas. The leiomyomas show bland proliferation of smooth muscle cells, and they do not exhibit, they are purely dermal in location, and they do not exhibit features of extension into the subcutaneous fat. In addition, of course, they have marked nuclear pleomorphism and mitotic activity or necrosis, then they automatically gets a diagnosis of leiomyosarcoma. But in early stages, when mitotic activity is not present and the nuclear pleomorphism is minimal, the two features which we should carefully look into are extension into subcutaneous fat and lymphovascular space permeation. So, just to talk a few words about cutaneous smooth muscle tumors. The benign ones are known as pilar leiomyomas. They are usually multiple and painful. Then you have the vascular leiomyomas, which are single nodules but are still painful. And then, of course, you have the malignant leiomyosarcomas, which are graded 1 to 3, we still use the FNCL-CC grading system when it comes to malignant features such as cellular differentiation, mitotic activity, and presence or absence of necrosis, and grade them as 1 to 3. And in most of these leiomyomas, the recurrence occurs in half of the patients. And when the tumor is purely dermal and when it involves the subcutaneous fat, they do metastasize. And subcutaneous involvement is more commonly seen in about 30 to 40% of cases. That is in summary, cutaneous leiomyomas or leiomyosarcomas. Now, the large majority of cases are benign, and they generally arise from pilar, in a pilar location, that is from the rectopili muscles. But of course, you do get painful single nodules which turn out to be vascular leiomyomas. We, I'm sure, have seen many vascular leiomyomas, and that seems to be more common than the pilar leiomyomas. Now, the next case is a 35-year-old who presented with a nodule on upper arm, and this patient had a significant past history. After you've seen the case, you will realize what the significant past history meant. Now, when you look at the sections, you see that there's again a circumscribed dermal nodule. And when you see the higher magnification, you see that the spindle cells have got tapered nuclei, and there are plenty of vessels scattered around in the lesion itself. When you look at the scanning magnification itself, you can see that these vessels are there all over the place. So there are plenty of these vessels amongst the spindly cells. And immunohistochemistry, obviously, when you have the spindle cell lesion, immunohistochemistry was carried out, and the important markers done were smooth muscle actin, SMA, CD34, etc. I'm just showing you in comparison a smooth muscle actin and an S100. So here you can see the smooth muscle actin have highlighted all vessels with the muscle around the vessels, and also some of the cells within the lesion itself. Whereas the S100 is relatively completely negative for the spindly cells, and we have the internal control showing the melanocytes and the dendritic cells in that S100 stained section of skin. So we clearly know that it has worked, and but sparing the spindle cell deletion. Now, is a hypertrophic scar. Now, usually surgical procedures. That is why I said this patient had a significant past history. He had something removed earlier from that lesion, so it was just an exuberant scar. Now, the scar formation could also be due to a previous inflammatory process. It's not always necessarily following a surgical intervention. Now, microscopy shows proliferation of spindle cells amidst the thin-walled blood vessels. And previous history is very crucial. That is what we miss most of the time. We as pathologists, when we look down the microscope at some of these lesions, we hardly get to know what has happened to that part of the skin, or what that part of the tumor, or that part of the lesion which we are looking at. We rarely get any past history. So in such occasions, past history is very, very crucial. Now, differential diagnosis is a low-grade spindle cell sarcoma and a desmoplastic melanoma. Now, of course, when I say desmoplastic melanoma, you do need to take into consideration the age of the patient, the location of the lesion, and also other features which we will come in discussion in a minute. But low spindle cell sarcoma is always a nightmare trying to decide whether this is some kind of low-grade proliferation of spindly cells, or is it just a scar. And in such occasions, again, a past history of some lesion having been there a while ago, or some minor surgical procedure being performed a while ago would be very, very crucial. And exuberant scars usually tend to progress to keloid. So scar, in my practice, I've always found deciding something is a proper scar when you don't have a history is always a nightmare. Also, when you have a low-grade spindle cell sarcoma re-excised, then again trying to decide whether there's a residual low-grade tumor and not a scar is again another big problem. So scars with these spindly cells give rise to a lot of apprehension when you're looking down the microscope, particularly when you don't have a proper history. Now, this is what I meant by the keloid, which usually all of us have seen plenty of keloids, I'm sure. So this extensive collagen formation, and when it reaches a keloid stage, it becomes all the more easier to decide that it's absolutely a keloid and nothing else. Whereas when it's hypertrophic scar, that comes into the differential diagnosis of all these spindle cell proliferations. Now, that is a higher magnification of the keloid, where you can see these spindly cells again is myofibroblastic or fibroblastic looking cells with plenty of collagen in between these cells, which helps us to decide that it's just a keloid. Now, the next case which gives us a lot of grief is this one. Now, this is a lady, 87-year-old lady, who presented with a nodule on scalp. Again, the age and the location is very, very important in these lesions. And here again, you see that the epidermis is markedly atrophic, being of that age and particularly on the scalp. And here you find a very, very ill-defined something going on in the dermis. So when scanning magnification of this lesion, you sometimes wonder, oh yeah, this could well be a scar. Particularly when somebody reaches that age, there could be plenty of reasons why you should or shouldn't have a scar on the scalp. It could be a previous phyllitis, or some BCC removed, or some actinic keratosis removed earlier. And the patients themselves may not think had happened. So you will never be able to guess that this is something nasty unless you look carefully. And this is such a very blunt looking, ill-defined lesion. Now, make a note of these lymphoid follicles which you see at the periphery. For some reason, this always seems to be a clue in these particular lesions. Now, lymphoid follicles, as you know very well, can occur in any chronic inflammatory conditions. You will find in chronic inflammation surrounding tumors, or chronic inflammation surrounding scars, or chronic inflammation in just an inflammatory condition. And even actinic keratosis, or for no particular reason, you may find some kind of, but this kind of when you have a lesion in that age group on a sun-exposed site, have a second look. Higher magnification shows mildly pleomorphic spindle cells again, and slightly, when compared to the scar which I showed you earlier, slightly pleomorphic than the scar, but not markedly pleomorphic enough to be, labeled as any particular tumor. So now, if you were to compare the scar which I showed you earlier, that looks like this, and here we have this ill-defined lesion, the only difference is you have these very prominent lymphoid follicles. But having said that, I have seen scars with lymphoid follicles surrounding it, but that is when you take the patient's details into consideration, such as the age, the site, and of course, then you look into the lesion itself quite carefully. Now, look at the immunohistochemistry. The S100 performed on the scar, which looks like that, which I had shown you earlier, and with that kind of internal control, whereas S100 performed on this lesion looks like this, with the cells staining almost all the cells staining brown here. So meaning that S100 staining is quite strong and diffuse in this particular lesion. Now, what is this? This is desmoplastic melanoma. Now, a rare variant of melanoma, as we all know, usually seen in chronically sun-damaged skin, and it is very, very ill-defined and prosy-seminar proliferation of cells, and the lymphocytic aggregates is a clue to diagnosis. And we should also note that desmoplastic melanomas are just S100 positive, but they're negative for melanA and HMB45. At electron microscopy have shown that the cells forming desmoplastic melanoma are not purely melanocytic. They still retain some of the fibroblastic characteristics. For that reason, they don't show the staining characteristic of melanocytic cells purely. So that is why they are melanA negative and HMB45 negative, and they're only positive for S100. You can imagine the situation when if only some of those cells are S100 positive and not as beautiful as staining as I have shown now, because even when you do an S100 staining in a scar, you may find some cells staining positive anyway. So that can add to the confusion, and also the biopsy is tiny, biopsy is superficial. Again, you're confused as to, oh, could this be a scar? Could this be a desmoplastic melanoma? Desmoplastic melanomas, again, another nightmare. They can be labeled as one of the difficult diagnoses to make when if you don't have a proper history and the biopsies are tiny. If you have a good excision like I've shown you, maybe with the in the right clinical context, you would not miss a diagnosis. But in my experience, that is one of the most difficult a diagnosis which we can easily miss. So, I tell my trainees, when you see a scar in an elderly person on a sun-exposed site, always have desmoplastic melanoma in the back of the mind and do an S100 staining. And also be aware that although desmoplastic melanoma is a melanoma, they are not positive for HMB45 and melanA. Of course, we have new markers such as SOX10, which helps to differentiate, as I know, but not all centers have started using SOX10, but that is also one of the markers which would help in deciding that it's a desmoplastic melanoma. Now, moving on, the
Sarah,
next case is...
Sarah,
sorry.
just for a second, the audio is a little bit muffled. Maybe if you can put the microphone or a phone a little bit closer to you.
Yeah.
Yeah, then now
is it better now?
Much better now. Thank you.
Okay, good. Okay. Now, moving on, the next case is a 25-year-old male who presented with thickening on the thenar aspect of the left hand. And this is the representative section. And again, you can see acral skin there with that marked orthokeratosis, slightly acanthotic epidermis, and in the dermis, you find this very, very ill-defined proliferation of cells with some areas of necrosis in the middle of the proliferation. I'll show you the higher magnification in a minute. There it is. So you have the cells here, but geographic necrosis of irregular geographical necrosis of the tumor. Again, the cells show spindle cells as well as epithelioid looking cells, and they have moderate nuclear pleomorphism. That is again higher magnification, spindle and epithelioid looking cells. Epithelioid looking cells have a lot of pink cytoplasm and they show moderate nuclear pleomorphism. Now, epithelioid cell sarcoma. Now, epithelioid cell sarcoma, as we all know, Enziger first described epithelioid cell sarcoma in 1970. They occur in young adult males, usually in the extremities. And they can present as just a thickening or a nodule, and it is again one of those clinical diagnoses which can have loads of differential diagnosis, and it could easily be missed. And histologically, I've shown you the classical features, and it expresses cytokeratin, EMA, and CD34 in half of the cases. And electron microscopy shows epithelial and mesenchymal features for these cells. So that is the reason why they're positive for cytokeratin and CD34. And cytogenetic abnormalities on short arm of chromosome 22 is seen in these cases. These tumors do not have a normal cellular counterpart. So whatever cells they arise from, it's still questionable. They do show hybrid features. And the differential diagnosis, if you're dealing with a small biopsy, you can again have problems dealing with making a proper diagnosis, because granuloma annulare, melanomas, and epithelioid vascular tumors can enter the differential diagnosis, because the cell type is a very varied kind of cosmopolitan type of cell type, where you have spindly cells sometimes, or epithelioid cells, and a combination. So the location, the age of the patient, and of course the morphology, if you have a good enough biopsy to see the geographical necrosis, then the diagnosis becomes slightly easier. So it has got very high recurrence rate, and 40% of these cases metastasize to regional lymph nodes, lung, and other locations. And studies have shown that older age, male sex, large size, and vascular invasion, and of course inadequate excision are adverse prognostic features. So they usually, when they clinically present as ill-defined lesions, it becomes very difficult to excise it completely, so they usually end up having one of the digits amputated, etc. They are such ill-defined tumors. And always when you have a punch biopsy or a tiny shave excision from the surface of the lesion, it becomes all the more difficult for the diagnosis to be confirmed, because you're only seeing part of the lesion. So that is the importance of getting a proper representative section, because there are a lot of features which come into play in making that diagnosis. Now, the next one is another interesting case. It's a female of 37 years who presented with a diffuse thickening of the shoulder. So here again, you can see the epidermis there, and then an ill-defined lesion within the dermis. So, nice storiform pattern of what we describe as rush mat appearance of these spindly cells. So you can see that nicely here. And the cells stain strongly for CD34. So the diagnosis becomes very obvious: dermatofibrosarcoma protuberans. And one of those not so uncommon tumor which you encounter on a day-to-day basis with regards to cutaneous spindle cell tumors. Now, it has got a bimodal population of cells, because some of the cells are myofibroblasts and others are fibrohistiocytes. CD34 immunoreactivity tells us that they could also be dendritic cells, because again, these tumors are classified in that broad category of tumors where the cell of origin is not clearly identified. People think that it could be myofibroblastic, dendritic, fibrohistiocytic, etc. And these tumors usually involve the dermis and the subcutaneous fat. In the subcutaneous fat, we tend to see this proper sieve-like pattern of infiltration of cells around the fat cells, and they're slender fibroblasts. They're arranged in a nice storiform rush mat pattern. So you tend to look for the storiform and diffuse strong positivity for CD34 to make this diagnosis of dermatofibrosarcoma protuberance. Fibrosarcomatous transformation occurs rarely, and if you have a mitotic count of more than 5 per, it's in fact 10 high power fields. I missed that 10, I'm sorry. So 5 per 10 high power fields and increased cellularity in a certain area, then you need to identify that area as a fibrosarcomatous transformation in a DFSP. And those tumors, it's not that they behave like fibrosarcomas, they're very, very 15% of DFSPs showing fibrosarcomatous transformation are known to metastasize. So these tumors do tend to show this fibrosarcomatous transformation, but they're very, very rare. Majority of the time, DFSPs are just proper DFSPs, and they are classified as tumors of intermediate malignancy. So although they have this terminology of dermatofibrosarcoma protuberance, they don't behave like a proper sarcoma. Moving on, the next one is a youngish female of 26 years who presented with a nodule on leg. Again, you see the epidermis, and you can see that it's a relatively circumscribed, but not quite a lesion in the dermis, but extending into the subcutaneous fat. Here you can see the inked margin at the bottom. And when you go closer, this is how it looks like. There are some lymphocytes scattered around, and these cells are small cells, short, spindly or stellate-looking cells, and they have this tendency of wrapping around collagen bundles. You can see the nice pink collagen bundles here, and the wrap around the collagen bundles, and also they just tend to get down to the subcutaneous fat. Higher magnification again shows the cells are very bland, uniform, they're short, spindly, and they tend to wrap around the collagen bundles. And these tumors are well known to show follicular induction. So this is obviously a dermatofibroma, and they characteristically show the follicular induction. The epidermis is usually hyperplastic, and this is what I mean by follicular induction. That is where you have the basaloid cell proliferation and including some sebaceous glands sometimes. So nicely seen, just overlying dermatofibromas. If to the inexperienced eye, this could well be BCC arising in the background of a dermatofibroma. But we all know that this is just follicular induction, which is seen in the background of dermatofibromas. Dermatofibromas, again, as we know, have so many millions of varieties of dermatofibromas which have been described, but the classical one has these short, spindly cells. But the usual, you have the granular variant, you have the pigmented variant, you have the spindle cell variant, some of them even looking like leiomyomas. So only when you do the immunohistochemical markers to differentiate do you realize that they are dermatofibromas. And as for immunohistochemical markers, we know that they stain vaguely or patchily with SMA, and they have this characteristic peripheral staining with CD34. That is, to differentiate from a dermatofibrosarcoma protuberance, if you use the CD34, DFSPs stain the CD34 stains DFSPs uniformly and strongly throughout the tumor, whereas in dermatofibromas, the staining pattern is just at the periphery. So edge staining for CD34. So they are usually solitary neoplastic or quasi-neoplastic lesions. Some people even think that dermatofibromas are reactive conditions and not real tumors. They usually present as nodular cellular proliferation. Collagen trapping is a characteristic feature, that is, they tend to wrap around collagen bundles. Epidermal hyperplasia and follicular induction is seen, and the CD34 edge staining pattern is typical. Again, this becomes useful when the lesions are small, and when you're trying to decide, oh, could this be labeled as DFSP or is it just a DF, then this CD34 staining pattern becomes useful. And there are so many different variants which has been described, such as a granular cell, more xanthomatous. Lots and lots of different variants of dermatofibromas have been described. Moving on, I hope I'm not boring you with all these spindly lesions. Now, a 45-year-old male who presented with a nodule on the thigh. And again, you can see, and there's a dermal lesion which has got these spindly cells, and there are some interesting structures you see amongst these spindly cells. And when you look at it, these are pseudorosettes. So you can see the spindly proliferation as well as the pseudorosettes here. High power of the spindle cells, you see that the cells have got a kind of neural or very edematous neurally background, and they are short spindly cells. So this is a dendritic cell neurofibroma with giant rosettes. Now, how did I make that diagnosis? Now, these are usually solitary, superficially located tumors in the dermis, and they have two cell types, type 1 and type 2. Now, type 1 cells are grouped around type 2 cells to form the pseudorosettes. Now, both cells are S100 and CD57 positive, and EMA stains the perineurium surrounding the tumor, and that suggests that they arise from the nerve sheath. These are entirely benign, and there is absolutely no evidence of recurrence. But these pseudorosettes are interesting, and these are quite rare. I have not seen many cases of these dendritic cells, neurofibroma with giant pseudorosettes, but occasionally in neurofibromas, you tend to see these cells aggregating together to form rosettes. That is kind of a degenerative or one type of phenomenon which you see when you have these two cell types in these tumors. Now, again, another case of spindly cell proliferation in the dermis, nodule on the side of neck in a 27-year-old male. Skin there, dermis, and you find these well-defined nodules which have got a very characteristic appearance. So you can see the dermis quite normally here, and then you have these very myxoid-looking, well-defined nodules within the dermis. And higher magnification, cells in the myxoid areas, they stain strongly with S100. They are stellate, and you can see the nice myxoid background for these nodules with those dermal collagen in between them being quite normal. And it is a neurothekioma, not a very difficult diagnosis when you have a characteristic appearance like that. Benign neural tumor. Most tumors are myxoid. They stain with S100 and PGP 9.5. And a variant is called cellular neurothekioma, which is characteristically S100 negative. And the differential diagnosis again is myxofibrosarcoma, because myxofibrosarcomas usually they do not form well-defined nodules like this, but they are very myxoid, and you have stellate or spindle cells in that strongly myxoid stroma. And of course, the immunohistochemical stains will help to differentiate. But in very low-grade myxofibrosarcomas, the nuclear pleomorphism is not that strong, and that again can give rise to some kind of grief trying to decide, oh, is this a neurothekioma or a myxofibrosarcoma? Now, again, moving on to a little more aggressive variety of lesions. This 67-year-old lady presented with a red patch on the breast. And again, when you hear such a story, immediately one thing will come to your mind. Oh, did she have anything in the past done? So we will have to find that out. So again, you can see the lesion, the epidermis is there, uninvolved, and there is a lot of spindly proliferation. At the same time, you can see that there are plenty of extravasated red blood cells and these dissecting thin-walled vascular channels there. And when you look at a closer magnification, still the striking feature, these dissecting thin-walled vascular channels with these prominent endothelial cells, and some of them showing mild nuclear pleomorphism. But the architecture is quite abnormal. When you see dermal vascular proliferation, that is quite well defined. If you see a hemangioma, that is a localized proliferation of small cells, small vessels, sorry. But here you find that these endothelial cells are, although bland, the dissecting nature of these vascular channels is very, very abnormal. And you also see these spindly cells around with such extravasated red blood cell formation in the surrounding dermis. So that is the CD31 staining, which diffusely stains all the spindly cells as well as the endothelial cells in the vessels. So you can see the vessels quite nicely there. And that gives away the diagnosis. So now we know that by this time, we have found out that she might have had carcinoma of the breast few years ago and followed by radiotherapy. And following this kind of ecchymotic patches or diffuse thickening on the same side of the breast must have resulted in this lesion and this radiation-induced sarcoma, and it is usually angiosarcomas that we see. So angiosarcomas and sarcomas otherwise specified is what we see, and the example which I showed you is clearly an angiosarcoma. So 5 years survival was 45% in a series published recently, and stage of location of sarcoma were considered to be the deciding factors. Of course, we know for sure that angiosarcomas are deadly sarcomas, and we don't even grade them because they are always considered as high-grade tumors. And more recently, and in the recent times, yes, because of the treatment for carcinoma of the breast is breast conservation with localized removal of the tumor following radiotherapy, we tend to see more and more of angiosarcomas following radiotherapy for breast carcinomas in the past. And the shortest interval we have had is a year after radiotherapy. A young patient recently presented with angiosarcoma on the same side of the breast. So I think I have taken you through to a spectrum of cases of spindle cell proliferation within the dermis. Of course, we have spindle cell tumors in the deep muscle and deeper locations, but this is dermal spindle cell proliferation ranging from dermatofibroma to scar to desmoplastic melanoma to other uncommon, maybe a bit of rare tumors such as epithelioid cell sarcomas and neurotheciomas, and finally radiation-induced angiosarcoma, which is now becoming quite common because of the treatment process which we follow for breast carcinomas. I think that's all I have for the moment. I hope you all enjoyed the talk, and I would like to thank Laszlo again for asking me to do this presentation, and which with the new technology which I have been experiencing for the first time, I thoroughly enjoyed talking to you. Thank you and good night.